beautiful health and doing very well in their perspective in every field of cardiology, day-to-day life. And today I was requested by Smit and Saujayta to speak for like calcium management with a special reference to orbital atherectomy. Now, this orbital atherectomy has reached many parts of our country, and Surya, my senior colleague, he has experienced orbital and Kapadi and many other people in India. Now, this orbital, why not rota? This debate will continue for a long time. I think the most important part is the learning curve of IVL is the shortest. Then I will put orbital, then the rota. Out of these three newer devices, rota was there since 1987. Orbital is there for quite some years, and IVL, perhaps does not take any learning curve. The cutting balloon, etc., I'm not going to discuss. Rota, I'm not going to discuss. So let me share my screen and welcome Dr. Vijayvergiya.
Hi. Good evening, everyone.
Good evening, sir. So this is basically a console, and if I can demonstrate here, this is the crown 1.25. I'll go in the detail. The Viper wear is just like a PTCA wear. The difference between rota and Viper, is much more maneuverable and much more user-friendly. And it does have a break at the tip. That means there is a change in size of your Viper wear and the radio opaque part, so that the whole system does not come out and cause perforation. This is 6 French compatible, and it can be from radial, femoral, anywhere. And the prep time is very short, and this wear usually can be advanced to the coronary artery. If you have difficulty, then you can use some microcatheters, and on microcatheter you can advance this. Then this is the button, the green button, and the green button, there is like Rota Pro, there is a switch. Once you touch that, the whole system gets activated. And this is a play zone. Like Rota, usually you start from here, so then you go forward and backward, go forward and backward. Out here,
can you share your screen, please? Dr. Hajra, can you share your screen?
Oh, please? Sorry. I think I was not sharing my screen. Sorry. I'm extremely sorry. Okay. Now can you see?
Yes, we can very well see.
Sorry. Okay. And sorry. So I'll start again, friends. So this is the diamond back, 360 degree or 360R. I do not know, because it takes care of 360 degree calcium. This is 1.25 bar, and this is Viper wear. And this wear, just like a coronary guide wear, and it can be advanced in a very tortuous system also. But if there is too much of calcium, where normal wear takes a little bit of time to get advanced, you can take microcatheter. You can push the microcatheter like CT operators they do, and then you exchange the microcatheter to the Viper wear. And the torquer is a usual torquer, but they usually provide a different torquer, and it's a 6 French guide. And the preparation time of this device between your IVL and Rota, it falls in between. The quickest learning curve is IVL, quickest preparation time is IVL. The stiffest learning curve is Rota, and the longer prep time is your Rota. So it falls in between. The price-wise, IVL on the higher side. Rota Pro definitely is on the higher side. In my hospital, with all the GST, etc., it costs around 2 to 2.5 lakhs. Now, one size fits all, and this is a green bar. It's a green button, this black button, like Rota Pro. If you touch, it's very touch sensitive. If the whole system gets activated, but it gets activated under certain conditions, like your brakes should be down, your this glide solution should be of adequate amount. So if your glide solution comes down below the accepted level, like that's why we take 1 liter of normal saline and then put the lubricant. So if it falls below that critical level, the automatically everything stops, and that is sometimes can be disastrous, but usually we take 1 liter and then a wiper slide. If you take 500 ml, be careful that you have to refill the whole system again with the saline and again with the glide. So 1 liter is important. Then there is a brake. I mentioned that only 2 buttons, one for 80 and another is 1,20,000. There are only 2 speeds, and this is the pump. And you just if I can show you, can you see, Prakash?
Yes, sir, we can.
We can.
Yeah.
Yes.
So this is the basically the crown, like it is very tiny one, and I'll show in the picture. And this button is very user friendly. So once you touch that, it automatically gets activated.
Hello.
And this is the saline and the glide solutions and the electric connections. And this brake goes down, goes up, and the wire comes out from this. So one operator can handle the whole system, and that's why it is called like
ऐसा देख लीजिए सर, इसमें सबकी फोटो और आ जाती है, ये भी ठीक है, और इसमें अगर बड़ा करना है सबको एड्रेस में, तो ठीक है, दोनों ये ठीक है, बड़ा है एड्रेस
Dr. Mukul, kindly mute yourself.
और अंबुजा सर ने बोला वो कल राउंड पे दे देंगे, ले आएंगे, बाकी बहुत से भी बात हुई थी और स्वाति से भी ले आएंगे।
others?
मेरी प्रवीण बोस की और नरेश सर की हैं, एक आपकी बताइए।
Right. So you have here glide assist. Glide assist means if you press the first button here, the 80,000 button size, it gets activated, and it should be on that position for some time. Then this glide assist system is activated, everything is prepared. Then it rotates at very low speed, and once this bar is inside guide, then only you should activate this glide assist. Unlike rota, what you start outside, you start inside the guide catheter here. Slowly you can advance, and once it is outside your guiding catheter like rota, this has to be. You can start from the proximal to distal. In the ostial lesion, you can go inside the vessel, then come back. But ostial lesion is a kind of contraindications for your orbital, but only the experts can use for ostial lesions. So this actually moves like this. And once you increase the speed, the centrifugal arc also increases. The diameter of the artery is increased from 2.5 to 4 millimeter coronary artery it can feed. And there is sometimes a wire bias, like any rotational device, whether you take 1.255 or 1.75. And the IVL is a king of corners and queen of the. For tortuous, like 2 bends usually should be avoided, and very small vessel with tortuosity definitely should not be used. And it moves like this. And rotational atherectomy is forward cutting, everybody knows. So you have to spend a lot of time. So time spent on orbital is much higher than the time spent on IVL and rota. Another thing, once your rota bar goes inside the coronary artery, you are sure that it has created enough space so that your next device, a balloon or your stent, can go in very easily. But out here, since the device is very slick 1.25, the passage of the orbital does not guarantee you that you have cut enough. So stay at the maximal calcific zone for longer period of time, lower speed. You can go at lower speed very slowly, then come back at higher speed. So these permutation and combinations can be done. But the dictum is go slow, come back slow at lower speed, few runs, and every 30 seconds you have to wait because you produce heat, and the chance of slow flow and low flow is much lower than the rota, and it can cause dissections, it can cause perforations like rota. Usually you don't need a temporary pacemaker. Now the bar size, as I said, this is the weakest zone, and it can break here, so it can get stuck, and it can break here, and the 2 micron particles is the usual size of the diamondback, whereas it produces a larger particle, and you one catheter, one guiding for diamondback from 2.5 to 4, whereas if you really want to use in 3 millimeter or larger vessel like main, you have to use a higher size of the guide and definitely higher size of the bar. And this preparation, as I mentioned, and the play zone is around, this zone is 8 centimeter play zone, and so this wire, this is 1/4 wire, and rotational is 0.09, much difficult to handle. And this distal spring, this zone is also very important, and this zone is prone for fracture and can snap here. So very careful. So keep around 25 to 20 to 25 millimeter distance between your crown and the distal tip. So this wire is 1.4 grams, 10 millimeter black part, and these are the different metrics. And this guide wire is 5 millimeter from here. So this cone is around from here 6.5 millimeter. From here to here is a 5 millimeter. Now, if you lose this nose in the larger coronary, it still can be compressed with a stent, but sometimes it is very difficult to take it out from the coronary artery. You can use snare, other things, but it can be buried. Unlike your rota, it still can be buried. It can be compressed to some extent, but not to a large extent. This crown usually comes out, but this whole portion, the nose cone, remains there. So drive side is 135 centimeter, and it can be negotiated. Now, if you start this like your orbital and low speed, there will be initial suction. So this initial suction can take your the guide inside the coronary artery, but with time, I'm here. I can come over. So this can suck in, and be careful that you are putting a lot of time and effort on the most difficult calcium. Once the calcium gives away, the like rota, it can jump. So you be careful not to go too distal. You can still go distal, but you have to keep a distance between the radiopaque part and your crown, and you should be careful that it should not jump. Now, this is the initial experiment, and this come over to MRI. Come over to MRI. I mean, lecture I'll be free within half an hour. Come over. And these are the particles, and one size fits all. I've already told you. Now there is rota fatigue, similarly orbital fatigue. I'll show you in case if you use this same bar for a long time, like 30 minutes you're using for right, circumflex, and lat, perhaps the diamond tips actually they become very polished itself and does not work. So you have to take another modality or another bar sometimes. Usually the wear doesn't cause any kink problem, but be careful, like any other device, the wire should not get kinked. And the speed I mentioned, these are the advantages. And this centrifugal force, this equation you must know that it all depends on the speed and the time. So there are different cuts. Like if you go very slow with low speed, it cuts the best. And that it is basically orbital cutting. And if you understand this diagram here, you go slow, you usually cut like ribbon, like the DNA ribbon. But if you go fast, you're actually stretching the spring, and usually less cut. Not all calcium is same. It can cut, unlike your IVL, it cannot do anything on the medial calcifications. It can reduce the volume of calcifications. It can break. It can produce a lot of cuts, nice cuts in the calcium. It can be seen both in ultrasound as well as the OCT. And this calcium, once you remove this calcium, the arterial behavior, the compliance of the artery changes, the vasomotion also comes like your rota. And these are the calcium where you can start from distal, go slowly into the mid, and you can always come back. It cuts both ways. That is the biggest advantage. You can, once you have a proximal cut and you go in the mid segment, and then you can stop there even. Like unlike rota. So usually rota do not get stopped at the lesion, never. It always comes back in the guiding. But once you have this kind of initial cutting, even if you stop by mistake, you should not be stopped. But if you stop by mistake, usually nothing happens because it's a small device. The wire, again, you should not keep any other wire like rota. It can cut the other wire. Nobody has tried on microcatheter, keeping in the circumflex. It is not recommended. Now, the visibility of orbital is much less than your rota or IVL balloon. So sometimes we do give injections. The calcium solute becomes your lighthouse for your bar. But once you press the cine, it becomes very prominent. So intermittent cine gives you an idea where you actually the bar is moving, and then you follow by with your like cutting balloon or IVL in addition, hybrid. The people have done laser orbital plus IVL we have done in Kolkata. So it gives very beautiful result. So these approaches, everybody knows. I'm not going to the detail, and this is usually seen nicely. The morphological cut, the volumetric cut, the volumetric reduction, morphological alteration, everything. Then you can work on this Viper, where the Viper slide, some people have used in CTO. Like there are some cases in TCT where nothing has crossed. The Viper coated small balloon with a glide solution were able to cross the lesion. So sometimes we have used it once to cross a CTO lesions when the balloon was not crossing, but it could be just a chance. But there are cases reported where your gadgets or microcatheter do not cross. So you rinse the microcatheter with the Viper glide solutions, and your microcatheter can reach your target. So when the microcatheter fails, balloon fails, the tonus fails, these are the glide solution which can help you. So this is one of the very difficult case. Right coronary artery, the left was done previously. Long calcified lesions, and there was no pacer. There was distinct calcium nodule. Initially, nothing was going in. So you have to pre-dilate it to image it. But even the balloon dilatations were not able to pass the OCT catheter. So then we started from the proximal. You can clearly see that slowly we're actually moving towards the mid segment. And then that where unlike your rota, even if your wire moves, then you come back to this glide assist, and with the torn, you can always reposition the wire like your coronary wire is much more comfortable to repositions. And it can, if it comes back to your wrong branch, again, you can re-advance into the desired destination. So that's the beauty of the wire. So slowly we gone into the distality, and we kept it there. And the nodule, nodule is very, it's a different animal altogether. Everybody has experience in their life. You have to spend more energy, more time. And out here, the rota cut, the distal, there is no slow flow or no phenomenon. And once you have done this, then usual balloon, sometimes you can use a balloon. Further, and I tell you, the passage of the stain was so good, and we could put, I think, 2-3 stains in the call.
You're always on the phone. You don't
So,
you help. Manju help who's calling you. No. It is just a missed call.
so these are the cuts on the OCT in this patient, and we could finish with good result, and patient is doing reasonably well. And okay, so I'll stop here. So this is the case I have shown, and I will invite some comments from Prakash and my other members so that it will become much more interesting. Over to you, Prakash. Vijay, Rajesh.
Azraji, very good. In short time, you have enlightened about the device features and the advantages and the cases what we have done. I appreciate that. It's a beginning in India. Maybe I think they must have done some 200 cases in India. And my experience is around 10 cases we completed today's case. So definitely it's an advantage that the learning curve is very short. And we have taken up some cases of symptomatic tight lesions with calcium. There I have noticed the slow flow phenomena came. I anticipated, even though they say that it's very less when compared to the rota and the things. So fortunately, I have kept a venous sheath, and both times I could bail it out. The second important thing is the same wiper wire is advantage. We can send the balloon on it and bail out. That's another big advantage with this. And as you know, everybody is now more than 90% radial operators. It's a big boon for the radial operators and the patient also. And cost effective because the 1.25 bar can be used for multi-vessel. I think Hazra has done in the first case. I remember you have done for triple vessel in the first case itself. So that's one more big advantage of this device. Only thing, 3 things we have to remember whenever deal. Watch your hand coordination and on the fluoro, the movement of the, because the visibility of the device is not as the rota. That's one thing. If the fluoro quality is not good, you may be seeing like a needle, you see, and you have to coordinate the movement initially, always slow. I think that's very important, particularly the bends, and although it suddenly jumps, there the chance of perforation is there in this also. And second thing, the hemodynamics. And third thing is the noise. When you are cracking the calcium at the tissue portion, you should be able to understand that the period you have to limit and improve the hemodynamics and go ahead. I think these 3 things are very important whenever you're doing the device. But only I don't understand why this device has for a long time in USA, and it's just parallel or a little bit low than the rota still in USA, when it's so useful device as per our perception.
Yeah. Smith's laser also can work on this wire.
Great, sir. Am I audible now?
Yes.
Audible.
Okay. Lasers are the best part is when nothing is crossable, then it works the best.
Yeah.
You know, that part is there.
Rajesh sir.
Hi, so very nice presentation. There are a few points, as Dr. Rao has already mentioned. There is a concern about the slow flow and no flow phenomena. I had a case of say LAD, and then I had a no flow and a VT 5 times DC shock even, and then later on I had a cutting balloon and stenting, which was again of course OCT guided. I had a good result, but then this misconception that okay, this doesn't cause slow flow or no flow compared to rota is not correct. and one should be ready to take care of the slow flow phenomena. Those who are the rota operator are in habit of pushing the rota bar too fast, and this is the problem when you are using this orbital atherectomy. You have to go very slow, as rightly pointed out by Dr. Hajra. And this slowness is very much a concern about, because it's going to increase your ischemia time. Like Dr. Hajra has shown the first case of tight LAD lesion, and you are going to stay over there for a long time. You are going to cause the ischemia. So that is a concern, how to take care of this thing. So that is really a concern for interventionists, not to have too much of ischemia time. So that is one point. And then, of course, there are certain advantages. You can have a 6F guide compatible for all the type of devices. Regarding the speed, Dr. Haza, can you comment about 80 versus 120? When to go with the 80 and when with the 120? And is there any need to go ahead for, say, IVL or laser even after having
Yes, sir.
even after having the orbital? When the conception is that with the orbital you are going to have a size which is varying from, say, 2.5 to 5 millimeter vessel size, but despite that we are landed up with either laser, IVL, or cutting balloon. So any comment about that part?
Exactly. They say that the industry says it's enough if you do orbital, then deploy the stent. No, I think for a calcific lesion, the expansion of the stent is more important for the operator. We have done in most of the cases, as you said, either a high pressure NC balloon or the angiosculp or cutting balloon, or sometimes one case in IVL also. We have to, and then deploy the stent. I think it's a combination of many things to get the best outcome. But they say better to look at the OCT picture after your orbital, see the cracks are in depth, how much. That's more important when you use these more braking devices.
Right. So 80,000 versus 120,000, most of the runs should be done on 80,000. Most of the time should be spent on 80,000. That will create up to 3 millimeter. Like you were talking about a 360-degree calcium, that is not in 100% of cases. Most of the time, other side is okay. You have to break the tectonic plate. Now, if you go to 120, definitely your force is higher. The chance of perforation also higher. But that can create up to 4 millimeter, that can prepare up to 4 millimeter vessels. And a peripheral, peripheral orbital is having a different kind of arc. So there are a different crown. There is a mini crown also coming for CTO. So these are the future. So 80,000, 120,000, when you're coming back, like to left main, suppose you have the biggest advantage of orbital, like in one device, you can do rota, you can do left main calcification, circumflex ostia, you can come back to left main. You can treat the left main ostia also with calcium. The beauty is that if you increase the speed, it becomes a larger device. If you decrease the speed, it becomes a smaller device. So that adaptability is there. And now, if you have an ostial lesion, I would suggest not to go to 120 ever. If you have two angles more than 90 degree, two bends, I'll never ever advise to go at 120, even if you have big vessels. So I would always suggest that use additional device if you have prepared. To some extent, we modified the calcium bulk-wise. You have paralyzed the tectonic plate. You have weakened the tectonic plate. Now take care of that rest of resistance by your cutting balloon or IVL sometimes. And sometimes, once you cannot pass the IVL balloon, even their normal balloon, perhaps this is the device which can go inside your difficult coronary territory. Now, these are the usual points I wanted to highlight here. The rest I have already spoken and Prakash has already highlighted.
Dr. Haja, any comment about vessel size and the speed? See, 80 is the okay for each and every lesion, and 120 is the maximum one. So any
120, sir, for left main, definitely run should be done on large left main, because 80,000, nothing going to be achieved at 80,000, because it will create up to maximum 3 millimeter. Now, if you go to higher speed, let's suppose proximal LAD is 3.5 and 4 millimeter. You have to use initial 80,000 few runs, and then you finish either backward or forward with 120,000.
Any concern about, say, we do have a concern about rota speed and slow flow phenomena. Is there any concern for orbital as well?
As you have mentioned,
Speed and
yeah,
incidence of,
as I
say,
mentioned,
slow
it is
flow.
2 micron. It is 2 micron particle, unlike your larger particle rota. So theoretically speaking, there will be some slow flow, no flow, but the passage, I mean, the passage of a particle through the coronary bed by flushing and etc. will be much faster, and the slow flow, slow flow or no flow will not be a long lasting one. It will be a short lasting one. It will, I mean, not cause a havoc, unlike your rota. So I would say that slow flow, no flow is not never seen, but it is seen, but less catastrophic for the patient because the microparticle can pass through the coronary bed much easily.
Is there any theoretical situation where the orbital followed by rota to be used, or vice
Yes.
versa?
Yes, I think you are absolutely right. That last case, there was a case of so much of calcium from the LED ostium nodule, a long plate of calcium, hardly anything could get in. And they recommend you pre-dilate with your 2 millimeter balloon with, or a non-compliant balloon, create some space. We have exhausted all the, I mean, we have for half an hour you tried, and this is the first kit I felt. So my dictum is where orbital fails, rotational atherectomy may fail, but perhaps since this has not been compared in my lab, I cannot comment. But theoretically speaking, if the orbital fails, you can take out rota 1.25 and then 1.5 bars. Perhaps my gut says that it will work. So vice versa, if your rota does not work, tortuous lesions, though it is not recommended, half rota is recommended, half orbital also recommended. If you're not able to go all through the segments of the tortuous artery, you stay at the most critical part, I mean most calcific part, and weaken that calcific part and take care of the rest of the part where your IVL balloon can go in. So half rota, half orbital can also be done in severe calcium. So there's a half failure, like as you have said, orbital full failure. I had a case. Sometimes they're half failure. You cannot use any other wire like rota. You can use extra support wire. Here you cannot use any other wire. So extra support wire can do wonder in difficult coronary calcium. These are the advantages of rota. Definitely, each machine and each device has its own advantage and disadvantage.
Can we use the rota on the Viper wire, or do we need
No,
the rota?
never.
No.
What about the big side branches with osteal stenosis? I think there, I think it's because they say it doesn't close the side branches with the whatever physiology it is working. It won't close the side branches. That is our observation also. That it is safe in those cases. Orbital.
Right. Sunip?
I have one question. I have not used it so far. But do you think two issues? One is this wire is relatively king-free than the rota wire.
Yes.
So that's definitely because the length is 300 centimeter for both, I think.
Yes.
The other thing is you are going to use the lubricant for orbital. That means you need not use that cocktail vasodilator what we use in rota.
Yes.
We need not use it.
No.
Okay. So the other thing is in the right coronary arteries, I don't use temporary pacing for rota. What is the consensus? That's all.
They say, but it happened. Your right coronary artery, I think still I feel to keep a venous sheath 6 French until we get a full confidence. We have 2 cases like that, and fortunately that saved us.
Yeah, some people use aminophylline, like Shamin Sharma always mentioned that he uses aminophylline before starting, where you don't want to use a temporary.
Upon the type of the block, you see very tight stenosis with the bad debris, then you expect distal embolization even with this orbital.
Yeah. So, Jatto, are you there? Khalid, Dr. Shastri, Abhishek?
Sir, Dr. Amenbert here. Uh,
Yeah.
I wanted to know what is the difference between orbital versus what is this laser atherectomy? I have not understood. Is there two separate things?
So Smith can answer. Yeah.
Sir, orbital, I think what we have discussed, laser has few other advantages here, that it actually causes platelet inactivation. So platelet activation is not there, therefore the chances of no flow and reflow are very less. Chances of thrombosis post laser are also very less. Laser, though not recommended, but has been used even without guide wire also, especially in peripheral lesions. So sometimes even if your guide wire is not crossing, there also you can be guided visually and use laser. Laser has limitations that in very severe calcification, it does not does anything. It needs some organic matter to vaporize and then crack the calcium. So there has to be some organic matter behind the calcium or within the calcium, which can vaporize. It works with with photo energy, with heat energy, with some dottering effect and some breakdown of the organic materials, which causes vapors and blast of vapor. That's the calcium.
Right. And laser is
it
also
has to
good
be
if you have a
told,
thrombus. Yes.
I think it has to be explained very clearly. Both are totally different instruments and different principles and different targets.
Yes.
Yeah, his question is both are same. Both are not same at all. The absolutely different instruments and the rota. I mean, laser probably you can use in thrombotic lesions, fibrous blocks, whereas the orbital you don't use in the thrombotic lesions and the fibrotic lesions, only for the calcified lesions.
So one is abrasive and other is ablative. That is the difference.
Yes.
It's a good option for thrombus. If you have calcified right coronary artery, acute inferior, and you can use the same modality to treat both thrombus, platelet paralysis, platelet deactivations by laser, and also you can treat the calcium. And laser is a very good tool for your energy to be delivered beyond the stent, like IVL and laser. It delivers energy beyond the stent's wall. So if you have a stent regret or under expansion of the stent, this is the device which can melt or can weaken the stent strut and also can work on the tissues like fibrocalcific tissues behind the stent strut. So no other energy will work behind the stent strut. Here, in wrist stenosis, you have to use blood contrast or blood saline contrast or a mixed thing rather than, the contrast as an agent rather than a saline as an agent. Sometimes we start with saline most of the time, and half saline, half contrast also can be done. So the energy dissipated increases if you use a contrast laser versus saline laser. If you reduce by 50%, the strength also reduces by 50%. The fluency, other things, Smith can elaborate further. But laser, the same machine can be used for other purpose, like peripheral, aortas, subclavians for your infected pacemaker, and so on and so forth. So one machine has other purposes too in our modern day practice, but orbital cannot be used for your pacemaker. So this is the advantage of one particular facility available in the industry.
Yeah. So saline is recommended to be used when you're lasing. If you use contrast, it can be explosive. So usually contrast is used only when you have a under expanded stent and you want to expand it. Then only you use contrast, and it is something a daredevil's job that should not be used. It is not recommended that you use it with contrast because it causes a explosion. It causes a high volume of vapor formation, and that can rupture the vessel, perforate the vessel.
So what about blood laser, Smith? Is there any concept of blood laser without saline, without contrast? Just you inject blood?
I feel, sir, it would be also in the same region, because I have used it with accidentally with little bit of contrast. That was in an acute MI patient, young patient, where I found that there are no stenotic lesions, only thrombus. So there, I could visualize the air vapor bubbles being formed and getting, flown downstream.
Right.
Probably with
Yeah.
cut
Advantage is,
or with
yeah, laser can be used on simple PDCA wire like CTO.
yes.
If Prakash has crossed with microcatheter, he can take out the laser and can
Yes.
put this device on the normal coronary wire in the diagonal ones, then the LED, then circumflex. So one device can work in different segments. And activation time is the only disadvantage. But the newer laser, I think from South Korea, they will be demonstrating in EuroPC at this time. Perhaps it is coming like a laptop. This activation
2
time
to
is
3 minutes.
so the activation time definitely higher with the Philips versions, but a newer modality, newer laser system, it has become much slicker. Prakash, yeah.
Can I ask one question?
Yes.
Sir, so suppose if we have dilated a lesion and we
Yeah.
find it is also calcified and we find that there is some type 1 dissection or non-flow limiting dissection. In such situations, can we use orbital if it's not getting expanded? So
Initially they said they should not be like pre-dilated lesions to start with in a rota or orbital. It has to be de novo lesions. If that doesn't work and you are forced to use a balloon, try to use 2 millimeter or less than 2 millimeter balloon. And if you produce great dissections, like a large dissection, you should not use either rota or orbital. And grade 1 dissection, Steve can still use orbital or a rota, but all depends on like your imaging. If you see that imaging, it is long dissections and the flaps are very nasty flaps, you should not use. You should rather use IVL there. So IVL, beauty of IVL, it does not propagate. It's a different kind of energy kinetics. And you can use a 3.5 millimeter IVL in a 4 millimeter vessel, and you can go at 2 atmosphere rather than 4 atmosphere. The chance of getting more dissections using larger IVL balloon is also minimized by just inflating at 2 atmosphere. And we have done that. The 3.5 millimeter IVL, if it goes to distal LED, and it is 2.75, you keep it inflated 2.75 and produce less dissections. So you have to use other modality rather than orbital or rota if you have a nasty dissections. Rajesh can, Dr. Vijayvergiya can enlighten us.
Yes, one thing is we do come across a calcified balloon, non-crossable lesion where the choice of laser and also the orbital is of use compared to say rota ablation. The rota is also effective in this patient with say 1.25 millimeter bulb. So that's one thing. Second thing regarding the post balloon dilatation dissected segment, there is a concern of say pulverizing and damaging whole of the dissected endothelial layer with orbital and also rota ablation. With the rota, one to prefer to go ahead with a smaller size, that's a 1.25, though people have tried 1.5 and I have also personally tried 1.5. But same is still not true for the orbital atherectomy. When you do have such a large area to be covered and whole of the endothelium and the media can be damaged in a dissected segment. So I think it's not indicated in those with the iatrogenic dissection following balloon dilatation. Here comes the role of say rota ablation or of course the IVL as Dr. Hajra has rightly mentioned about. And as Smith has rightly mentioned about this laser therapy with contrast is something which has been tried only in those with calcified under expanded stent. There is the role, otherwise it's preferable to go ahead with the saline and not with the contrast.
Yeah, another will be like
Can I ask you a question?
Yeah, just a minute. Suppose you are not planning to put a stent, and nowadays the DEB concept also coming. If you have produced a little bit of dissections but sufficient lumen, which is long diffuse LED, and you have treated calcium, the flow is all right, you can get away with a long drug-eluting balloon. Rather than putting a stent and you regret later on. So if drug-eluting balloon gets restenosis, you can always again go for drug-eluting balloon or come prepared with your new strategy next time so that the patient feels better. So I would suggest is a combination of therapy. Sometimes you should know each and everything, and it can take out one thing for one patient and take out a different thing for different patients.
So there is now some school of thought that IVL should not be inflated to 6, as a last step. What is the logic behind it?
No, there are report of having perforation, and then recommendation is 6 to 8. Dr. Hazra has gone up to 12 atmosphere, if I'm correct. He commented in one of the case that you should go for the 12. In one of my live case been transmitted for the NIC, but then recommendation is 4 to 6 atmosphere, and which has to be for a newer therapy. Like the recommendation for the cutting balloon is say 8 to 10 atmosphere. We do go up to 18. It's the experience which has to come into picture later on, whether we can go from 6 and above with IVL therapy or not. But then recommendation just for now is up to say 4 and then 6 atmosphere. So let's follow the same. And then they are the report of having the coronary perforation as well. It's preferable to have the intravascular imaging done to choose the appropriate size of IVL balloon instead of going without imaging, and that's going to prevent you to have a complication like perforation. Oversized balloon in undersized vessel and going for the high pressure can create the problem.
Hello.
Yeah, exactly. I think this is the usual dictum that 4 and 6.
Yes.
Can I ask a question?
Dr. Rajesh, the calcific nodule, is it's a real problem if you find on the OCT. I don't think any device can give a perfect answer for this. What you prefer is need a combined solutions like a IVL and some orbital. I think it's still a area where there are deficiencies in the treatment.
Regarding the calcified nodule, till now we were treating it with the rotablation, and now there is a concern about say wire bias and eccentric lesion and non-effectiveness of rota when orbital and IVL therapy has come into the picture. But it's important to have how much area have you achieved after rotablation or other ablative therapy like cutting balloon, and then to decide about whether there is need for the IVL therapy or not. I had one patient, I can very well share in my newsletter. The patient had now 5 calcified nodule in the LAD. As he was not able to afford for IVL therapy, I used a cutting balloon and also the rota, and then achieved a good intraliminal area, confirmed with the OCT, had a 1-year follow-up angiogram with the OCT, which is absolutely fine. So that's all. So, but then there are few therapy like IVL therapy, orbital therapy, which can be helpful to have an improvement in the very severe calcified nodule, which is not been treated with the rotablation, and we are not able to achieve an adequate minimal luminal area at the site of the calcified nodule.
Right.
Good evening. This is Dr. Sumit. Am I audible?
Yes.
Yes, please.
Good evening, sir. Just had a question, and suppose everything has been done and finally you land up with a stent which is still underexpanded. And now what is the algorithm that you follow for such underexpanded stent? After trying your NC balloon, you have OPN NC balloon, and then you may go for some other techniques. What is the algorithm that we should follow?
So there is a statement recently I have presented the slide, I can very well share with you. Post stent, after doing each and everything for the calcified region, and still you are not that expanded stent. So there are only 3 or 4 options. First is NC balloon, OPN balloon, IVL therapy, and then laser therapy with contrast. So these are the 4 options which is there to take care of the underexpanded stent. And of course, people have tried doing rotablation of the stent structs, which I did, and I did in one of the case and could nicely demonstrate the stent ablation with the rota ablation in under expanded stent. Dr. Rao, Dr. Hajar, do you have any experience of say rota ablation of the stent stretch for under expanded stent?
No, no, sir. I don't have, but I use the IVL for the.
I think
After
I
doing
have
everything.
one case, Dr. Vijay, but it takes a lot of effort and courage to ablate stent with the rota. I have seen cases Dr. Shabin Sharma doing, and there you have to use a larger bar. You know, like suppose you are doing with a 3 millimeter stent, the artery to bar ratio will be much higher than your de novo lesions. And second, always there is a chance of stark rota. Third is extra support wear. And fourth is your patience. It takes a longer time to ablate that segment. But as you have said, if you have a stent regret, use IVL balloon, or nowadays you have a high pressure short balloons, like even your this Orbital, they have come up with 24 atmosphere, the OPN balloon, etc. But cutting balloon, etc. is not going to work if you have stent degrade. You have to use high pressure balloon or IVL or laser. There's three things it can be done.
Sir,
And
any
a big no to orbital in a stented segment. Kindly note it down.
Yeah. No orbital in a stented segment.
No orbital.
It's not going to work.
Sir, any data on the effect of laser therapy in such under expanded stent? Does it actually affects the struts, the integrity of the struts?
Only thing is you are actually vaporize the polymer. The drug, etc., gets vaporized if you use laser on recently implanted coronary stent, which usually does not happen with the IVL. IVL may happen. I'm just again guessing. The IVL also can damage the polymer and the drug. But definitely laser will take away all the polymers. Smith will agree with me that this high temperature will take away your polymer and drug from the stent, and it will be bare metal stent.
Thank you.
Yes, sir.
Hello. So this is the final music for the end of the session. Kindly conclude it then.
Yeah, so friends, I think we have enjoyed, and I'll hand over the session to Dr. Smith.
Being a working day, sir, we do find that a lot of disturbances are there. It was a great learning time, sir, and let's hope. And the great news is that Saujayta has started helping me in keeping this show going on. So today's all arrangements and everything was Saujayta's doing. I was only a kind of a guest appearance in the preparation part of it. And let's hope we meet, have good topics discussed often. And glad to see you. I think someone was introducing Dr. Rajesh Vijayvergiya. Somebody's wife was, curious to know that, okay, this is Dr. Rajesh Vijayvergiya. So morning also, sir, I was discussing in my cath lab and remembering you, telling my students, ये हो गया दर्द का काम वहीं से आया हुआ है. So let's keep together, sir. So next fourth Friday again we meet, sir. Thank you.
Thank you. Good night.